Hello, I am Dr. Purnashri. We'll be discussing the question papers from Orthodontics. This is the part 6. So in this part we'll be discussing management of class 3 malocclusion, management of cleft lip palate, crossbite, open bite, surgical orthodontics, retention and relapse, genetic factor in orthodontic, preventive orthodontics and orthodontic materials. So from management of class 3 malocclusion, previously short essays have been asked. Classify class 3 malocclusion and explain in detail management of class 3 malocclusion. So I've picked up this flowchart from Balaji. You can write this. So the class 3 malocclusion patient can be growing or a non-growing patient. And under these categories it can be skeletal or dental. Based on whether it is skeletal, dental, growing or non-growing, there are different treatment modalities. You have to explain all of these in this answer. Then under management of cleft lip and palate, long essay has been asked. That is, classify cleft lip and palate, discuss the etiology, clinical features and management of cleft lip and palate. So classification of cleft lip and palate, they can be classified broadly into typical and atypical orofacial clefts, and second type is syndromic and non-syndromic cleft. Other than this, there are certain classifications such as Davies and Ritchie classification, where they divide into 3 groups: prealveolar, postalveolar clefts and alveolar clefts. Then View's classification, where he divides into 4 groups, group 1, 2, 3, 4. One is cleft involving soft palate, group 2 is cleft involving hard and soft palate but up to incisive foramen, group 3 is complete unilateral clefts, group 4 is complete bilateral clefts. Then there is classification by Fogg-Anderson. Again here there is group 1, 2, 3, where group 1 is cleft of lip, group 2 is cleft of lip and palate, group 3 is cleft of palate extending up to the incisive foramen. Then there is symbolic classification given by Schuchart and Pfeiffer. So this is the symbolic representation. There is left and right side, and each rectangle represents a part of the anatomy. So the first boxes represent the lips, the second one's alveolus, these two represent hard palate, and the triangle in the end represents a soft palate. These boxes are colored. If they are colored fully dark, then they are total cleft, and if it is colored grey, it is partial cleft. Then there is Kernahan's striped Y classification. This is the diagram for that, and each block has a number and each of these blocks represent a part. So 1 and 4 represent the lip, 2 and 5 represent the alveolus, 3 and 6 the hard palate. This circle here is the incisive foramen. So these are the hard palate anterior to incisive foramen. Blocks 7 and 8 are the hard palate behind or posterior to the incisive foramen, and block 9 is the soft palate, and these are also shaded similar way. Then there is LaSalle classification. So they have given an alphabet. So L stands for lip, A for alveolus, H for hard palate, S for soft palate, and the same way it is repeated here, HAL. So this is the diagrammatic representation. So when we write the classification, if it is on the left side lip, cleft on the left side, then we'll write the first L. Then there is clefting of the alveolus and the hard palate. But if there is no clefting of the soft palate and no clefting on the right side, then we'll put a blank there. We'll leave LAH and then blank, blank, blank. So that is how we write the LaSalle classification. Another question that has been asked is classify cleft lip and palate, that we have discussed in the previous question. Then discuss the etiology, clinical features and management of cleft lip and palate. So when it classify cleft lip and palate, if it is asked as a part of a question, you can write any 2 classifications that you know well. Then discuss the etiology. Etiology, it can be hereditary or genetic. environmental or multifactorial, you have to explain under these headings. Then the clinical features you have to explain under the headings of dental, skeletal, speech and hearing, and psychological features. You have to explain the factors under these headings. Then coming to management, you have to explain about the multidisciplinary team management. So whenever a cleft lip and palate is there, you have to explain about this and the 4 stages under which it is treated. Coming to the short essays, describe the team approach in treatment of cleft lip and palate and stages of treatment in detail. So this is again a part of the previous question. I'll be explaining in detail here. So the team approach means there is multidisciplinary cleft palate team. That includes an ENT surgeon, social worker, nursing support, speech therapist, psychiatrist, ophthalmologist, pediatric dentist, orthodontist, prosthodontist, plastic and oral surgeon, and a genetic scientist. So all these different disciplines together help to treat a cleft lip patient, cleft lip and palate patient. That includes the team approach. Coming to the stages in management, they can be divided into 4 stages. So stage 1 is done from birth to 18 months of age. Stage 2 is the treatment from 18th month, that is 1.5 year to 5 years of age. That is basically the primary dentition stage. Stage 3 is the mixed dentition stage from 6th to 11th year. And then 4th stage is the treatment during permanent dentition. This is from 12 to 18 years of age. So under stage 1, we have fabrication of passive obturator, pre-surgical orthopedics, and then surgical management of cleft lip and cleft palate. Then stage 2 comprises of the treatment that is carried out during primary dentition, that is adjustment of the obturator, checking if the teeth are erupting properly, then oral hygiene instructions and restoration of decayed teeth. Stage 3, the mixed dentition period, it's mainly to prevention of dental diseases, and then secondary alveolar bone grafting can be done during this stage. Then stage 4, that is the permanent dentition treatment. There is definitive orthodontic treatment that is carried out, and then if there is any hypoplastic maxilla, face mask can be given, and alternatively surgical options can also be discussed. Coming to the short notes that were asked, Laschal classification, this I have explained. Moving to the next topic, management of crossbite. Here short notes have been asked. Management of developing crossbite. So when there is a developing anterior crossbite, tongue blade therapy can be used. Alternatively, a lower inclined plane therapy can be used. And if there is a developing posterior crossbite, expansion appliances can be used. Then Catalan's appliance. So Catalan's appliance is basically the lower anterior inclined plane. You can see here, you can draw this diagram as well. So it is used in cases where crossbite is due to palatally placed maxillary incisors. That is, anterior crossbite is there, and if it is developing, this appliance can be used. It is constructed at 45-degree angulation to lower anterior teeth by acrylic or cast metal. Moving to the next topic, management of open bite. Here also short notes have been asked previously. What is management of open bite? So management of open bite, based on the etiology we can manage. If there is dentoalveolar open bite, it can be managed by habit control and thus the elimination of perioral musculature. Then if there is skeletal open bite, and if it is during the growth phase, we can redirect the growth. And if it is after the growth phase, we can do extraction and treatment by orthodontics, or if it is severe, then we can go for an orthognathic surgery. And management of open bite based on the timing and determination of growth pattern, it can be divided, and the type of dentition, it can be divided into management in deciduous dentition, mixed dentition and permanent dentition. You can explain the management under these headings. Then habit control includes the lip seal and swallowing exercises. growth modification to control the vertical growth and the posterior dentoalveolar development. Then there is orthodontic camouflage, where there is only orthodontics, and the orthognathic surgery, where there can be combined orthodontic and orthognathic surgical mode of treatment. This completes the management of open bite. Coming to the next topic, lab procedure. Here also short notes have been asked previously. Soldering in orthodontics. So soldering is basically defined as the joining of metals by fusion of filler metal between them at a temperature below the solidus temperature of the metals being joined and below 450 degrees centigrade. So the main point here that you have to mention is about the filler metal that is used between them, and that the temperature is below the solidus temperature of the metals and the total temperature is below 450 degrees centigrade. So these 3 points, if you write, your definition for soldering will be complete. The next question is sensitization and stabilization. So these terms are usually used in reference to stainless steel. Sensitization means when we cold work the stainless steel, the carbide precipitates along the slip planes. As a result, areas deficient in carbon will be less and the carbide is uniformly distributed. They precipitate only in grain boundaries, and this will increase the corrosion resistance. Because of the precipitation of carbide, there is increased corrosion resistance. This is called as sensitization. And what is stabilization? When there is introduction of any element which precipitates as carbide instead of chromium, that means it helps the carbide to precipitate. Example is a titanium. When titanium is added 6 times to the carbon, it inhibits formation of chromium carbide and thus it reduces the corrosion. The next short note is Nitinol. So Nitinol is a word that is derived from nickel, titanium, N for naval, O ordnance, L laboratory. So when we come, basically Nitinol is the short form for this, nickel, titanium, naval ordnance laboratory. Then this was discovered by William Buehler, who was a scientist in Naval Ordnance Laboratory in Springfield, Maryland. It is made up of 55% nickel and the 45% titanium. Then you can write about the two phases it exists in, austenitic and martensitic. If you have time, you can also mention about in short about the properties of Nitinol. Then the next question is properties of stainless steel. Stainless steel has many properties. The main general properties that you can write are sensitization, stabilization, ductility and malleability, soldering and welding, strain hardening and heat treatment, that is annealing, and the hardening heat treatment that is carried out for stainless steel. The next question is impression trays used in orthodontics. So we'll start by defining an impression tray. It is a device that is used to carry, confine, control. So 3 C's: carry, confine and control impression material while making an impression. And in orthodontics we usually use a stock tray which can be perforated, non-perforated or a rim lock tray. We usually use the perforated trays in orthodontics, and based on the material used for fabrication of the impression trays, they can be either metallic or non-metallic. The next question is alginate impression material. So alginate is classified under irreversible hydrocolloid impression materials. So alginate is derived from the term algin. Algin is a mucus extract that is obtained from the brown seaweed or the algae. Then you can write about the applications of the alginate, and this you must be knowing for impression making, for primary impressions in CD, and orthodontic study models for duplicating models. Then the composition, you have to remember this composition. Sometimes this can also be asked as a short note. Next question is acrylization. The base plate used in orthodontics is fabricated using methyl methacrylate resins. So the processing of these acrylate resins is called the acrylization. The methods are using the self-cure acrylic, heat cure acrylic, and using thermoplastic sheets. When we use self-cure acrylic, two methods can be used, that is the salt and pepper method or the single mix method or the Dove method. Next topic is surgical orthodontics. Here we have a long essay. Classify and list the various procedures of surgical orthodontics. Describe in detail about extraction in orthodontics. So the different surgical procedures in orthodontics, we divide them into major procedures and the minor procedures. Major procedures include the orthodontic surgeries and the cosmetic surgeries, whereas the minor procedures include the extractions, surgical uncovering of teeth, that is if they are impacted, then there is frenectomy, pericision and the corticotomy. Describe in detail about extractions. This we have already discussed under the topic of gaining space in previous videos. Then you can explain about the types of extraction in orthodontics, that is therapeutic extractions, that is extractions carried out for orthodontics. Then there is serial extraction, then extraction of carious teeth, malformed teeth, supernumerary teeth and the impacted teeth. You have to explain about all of these types of extraction and when is it carried out. Under short notes we have austenitic stainless steel. Austenitic stainless steel, its composition is iron, chromium and nickel. These are the composition where there is 16 to 25% chromium, 7 to 20% nickel. It is called austenitic because it has a face centered cubic structure and then it remains in the austenitic form, this type of stainless steel, at normal temperature. The advantage of this is it has better corrosion resistance than the other types of stainless steel because the carbides can be retained in solid solution by rapid cooling. That is the advantage of austenitic stainless steel. Most of the pliers that are used are made out of austenitic stainless steel. What is pericision? So pericision is also called as CSF. That means circumferential supracrestal fibrotomy. So CSF is the short form for this. This is a minor surgical procedure where we undertake this to prevent the relapse after the orthodontic treatment due to the stretched gingival fibers. So two main points is to prevent the relapse because of the stretched gingival fibers. How is this done? So we use a small sharp scalpel and it is placed in the gingival sulcus and around 2 mm apical to the alveolar crust the gingival fibers are cut. It is undertaken as an adjunctive retention procedure after the correction of rotations. Usually when we derotate teeth, this procedure is used to prevent the relapse. Then other questions that were asked are short notes, reverse orthodontics and pre-surgical orthodontics. These two are somewhat similar terms. So pre-surgical orthodontics means it is aimed at removing the natural compensation. That is basically is called as the decompensation, is called as the pre-surgical orthodontics. For example, in a mandibular prognathism, that is class 3 patient, the lower incisors are usually retroclined, that is they are compensated because of the prognathic mandible. These incisors should be brought to their ideal or the correct inclination. This is called as the decompensation and this is what we do in the pre-surgical orthodontics. And another example is if suppose the mandible is retrognathic, the lower incisors will tend to be proclined. So to correct this, teeth may be extracted and the ideal inclination is brought. So this is the pre-surgical orthodontics. So because the decompensation makes the maxillomandibular relationship worse temporarily, it makes it even bad. That is why it is called as the reverse orthodontics. This is the answer for this question. Then the next topic is retention and relapse. Long essay that was asked is define retention and relapse, explain various causes of relapse and how to prevent them. So orthodontic retention is the final stage of orthodontic treatment which aims to maintain teeth in their corrected positions after completion of orthodontic treatment. Then we define relapse as the loss of any correction achieved by orthodontic treatment. The various causes for relapse, I've listed them out here. It can be patient age, length of retention, mandibular rotation, arch dimension, presence of third molars, tooth size, apical base, position of mandibular incisors, the habits and the skill of the operator. Short essay, we have enumerate various theorems of retention. So there are totally 10 theorems that are there. I've listed them out here that you can find it in any of the textbook. You have to write these down. You have to memorize these and then write these down and add a note on removable retention appliance. Removable retention appliances are passive appliances. So they are not active. They do not cause any teeth movement, but they are passive. They just hold the teeth in their position that can be removed by the patient and reinserted at will. The examples will be Hawley's appliance, Begg's appliance, clip-on retainer or spring aligner, wraparound retainer, Kessling tooth positioner and invisible retainers. The next question is define retention. Discuss the schools of retention. Retention is defined as maintaining newly moved teeth in position long enough to aid in stabilizing their correction. This is given by Moyers. And coming to the schools of retention, there are 4 schools of retention: occlusal school, apical base school, mandibular incisor school and the musculature school. You have to explain about all these 4 schools of retention in this answer. Who gave it and what does it say? And short essay, theories of retention has been asked, and short notes, schools of retention has been asked. So you can just name the theories of retention for the short essay and explain it in short, and for a short note, schools of retention, you can just write the names of the 4 schools of retention. Next topic is genetic factors in orthodontics. Here short note that is asked is Butler's field theory. So this theory basically divides the dentition into different developmental fields, and the fields are molar premolar field, canine and the incisor field. What it says is the most distal tooth in each of these field is likely to show any variation. For example, in the incisor field, the lateral incisor is the distal most tooth, and this is more prone to variation than central incisor. Similar way, in premolars, the second premolar is the distal tooth and that shows more variations, and under molar field, the third molar is the distal most tooth, and as we know, the third molar shows the more variation than the second or the first molar. Under the topic preventive orthodontics, distal shoe space maintainer has been asked as a short note. So as usual, you draw a diagram wherever you can. Distal shoe space maintainer is also called as an intra-alveolar appliance because of the design that you can see here. You can explain the design of it and then the use of it. It is used to retain and guide the permanent first molar into normal eruptive occlusion. Under the topic orthodontic materials, this is the last topic that we are discussing as a part of this question paper discussion. Austenitic stainless steel and soldering have been asked. This we have already discussed in this video. With that, we come to an end. If you have any questions, doubts or suggestions, you are free to leave it in the comment section. I'll try to clear it as much as possible. Thank you.